So today our focus is on a clinical scenario which is on bicep rupture. So we'll start with a presentation where there's a patient who has actually lifted something heavy and now comes with a snap in the arm. He says that there's a bulge, and when you ask him to turn a key, he struggles. Right. Within the next few couple of minutes, we'll be looking at what the bicep is and what is its structure, how the contents are, and we'll look at the cubital fossa as well, which is a very important structure when it comes to the arm. But let me give you this. Now, this patient has presented with a bulge in the latter part of the arm, which means now that it has something to do with the structures that are found within the arm. Now, your initial guess should be that this is actually a bicep tendon rupture. But we'll go into the details and look at the clinical scenario so that we can come up with a good answer to the question that was given. Right. Now, when we look at biceps, the bicep actually has two heads, the long head, the short head, and the point at where it inserts itself. The long head is found through the bicipital groove and it gets attached to the supraglenoid tubercle. If you can see, right, this is the point. And if there is this short head which comes from the coracoid process and then merges with the long head so that we forms a single belly. Now, this complete biceps is then attached laterally to the radius. So, why two heads? It actually stabilizes the shoulder and attaches the elbow as well. Both heads merge into a single tendon and inserts into the tendon where it gets completely attached to the radial tuberosity. Now, another question is, since it is attached to the radial tuberosity, what sort of action does it actually do? Now, what I have already said is that make sure that you pull the tendon or the insertion towards the origin. Now, as you do this, the actual tendon surpasses the elbow joint. So what happens is that the elbow flexes. That is the normal action of the bicep tendon. However, what happens is that because of this orientation of the tendon, there's this possibility for the radius to slightly twist as well, rotation. So this rotatory movement is actually called as supination. So what does the biceps do? The biceps flexes and flexes the elbow joint, and also it causes a little bit of a twist so that it causes supination at the both at the elbow joint and at the point where there is the proximal radial ulnar joint. So now going into further action, we'll go into the latter part of the biceps. In the latter part of the bicep, you get something called the cubital fossa. This is an anatomical location, but make sure that you see this structure as well. If you look at this closely, there is this fanned out sheath like structure that is found at the terminal end of the biceps, which is actually aponeurosis. The aponeurosis is a sheath. So this aponeurosis covers, if you look at this in a little bit of a more precision, you will see that there is this artery and the vein that flows underneath the sheath so that it is given actual protection from the bicipital sheath as well. So this aponeurosis that we have seen is actually attached to the ulna. So the bicep has two heads, merges into a single one, and then it attaches to the radius, all right. But you see another sheath that is coming out from the latter part, which is known as the bicipital aponeurosis, that actually protects the artery and the vein that comes by. Right. Now the cubital, if you look closely to the cubital fossa is the region. This is that region. So if you look at the cubital fossa, it is of much clinical importance because now this is the point where You have seen most of the nurses when they draw blood, they use the easy access point at the clinical at the cubital fossa to get access to the cubital vein that is passing underneath. In anatomy, once you get to describe the cubital fossa, you need to look at its locations, look at its borders, in fact. So, as a matter of fact, you should know this is between the 2 points of the humerus, which is known as the medial epicondyle and the lateral epicondyle. So, the lateral epicondyle and the medial epicondyle, and the imaginary line that connects the two. Then the other borders are provided by two muscles, the forearm muscles. We have already gone through these forearm muscles as well. One would be the medial forearm muscle, which is known as the pronator teres, whereas the second would be the lateral forearm muscles that comes from the lateral aspect of the humerus, which is known as the brachioradialis. So these two provides the medial and the lateral borders for the cubital fossa. Now the flow of the cubital fossa is this, and what you would see is some important clinical structures that are found in midst. Usually, for remembering purposes, I use a mnemonic which is R10. R10. Right. So this would be the lateral aspect and this would be the medial aspect. Now, if you look closely, the most lateral structure that you would see in the cubital fossa is the radial nerve. Then you would see the tendon, the, the tendon of the biceps, which is the most important muscle that you would see in the anterior compartment of the arm. And then close by, you would see an artery which is of very much importance. It is known as the brachial artery that supplies blood to the forearm and the distal part of the arm. So this is the brachial artery that you would see medial and in proximity to the bicep tendon. Then of course you would see another nerve which is found medial to the artery, that is known as the median nerve. The median nerve is actually the nerve that provides sensation or the innervation, both motor and sometimes it plays a part in sensory innervation as well, to the muscles that are found in the anterior compartment of the forearm, and also some of the muscles which are involved in the movements of the fingers. So the cubital fossa is composed of these few structures. These are the underneath structures, but of course there are few cutaneous supply as well, but you need to worry only about the structures that are found in the among these boundaries within the cubital fossa. So for remembering purposes, R10 would be very easy. Radial artery, radial nerve, the bicep tendon, the brachial artery, and the nerve which is the median nerve. Right. Now, so if I sum up a little bit, there is this bicep which actually consists of the long head which is coming from the supraglenoid tubercle, and then the short head that comes from the coracoid process. These two merges together to form a single belly. Then it gets attached into the radial tuberosity, so found little bit laterally. Then you would see another sheath which actually comes from the biceps. This is known as the bicipital aponeurosis, the connective tissue, which provides a little bit of it's a sheath that fans out and then gets attached to the medial aspect of the arm, but it provides protection for the brachial artery and the concomitant veins that are found close by. So the brachial vein. Right. And then you see this important clinical structure that is present in close proximity to the elbow joint, which is known as the cubital fossa. And the borders, you should remember, the imaginary line that is present between the medial epicondyle and lateral epicondyle, the medial border that is provided by the pronator teres, and the lateral border that is given by the brachioradialis. So the contents are the radial nerve, the bicep tendon, the brachial artery and the median nerve. So these are given lateral to medium. That of course is a must know factor, because whenever you do surgeries within, assuming that you come up with the surgery in close proximity to the cubital vein or cubital fossa, you should know the structures to spare the nerves. All right. Now we'll go into the clinical aspect. When you come into the clinical aspects of this particular case, now as I said, this patient comes with the presentation of a bulge. This is the bulge. Now, frankly, I have up this picture as well. One cartoon figure that comes up to your mind is would be Popeye. Now, Popeye, who has missized forearms and also this bulge-like structure that is present for the biceps. Now, in such circumstances, if this patient says about a abrupt sort of a pain and the bulge has actually come up in a very quick time session, which means in a couple of seconds, then you should think that there is a deformity, not a congenital one, but a deformity that might have been because of a consequence of some rupture of a muscle. The usual muscle that ruptures is actually the biceps. The bicep ruptures in two positions. One would be long head. If the long head has ruptured by some means, usually this happens when the person exerts themselves and lifts something very heavy out of proportion that cannot be that is not capable in their capacity. In such cases, there is a possibility the long head might rupture, and then the bulk from the belly of the muscle will be bulging out at a more or less a proximal point of the biceps, at a upper place. But when you think about the bulge that is seen at the latter part of the arm, at the insertion, you would think sometimes it would be the rupture of the radial tuberosity, the insertion at the radial tuberosity. So because of the origins are still in shape, still in position, it would frankly be lifted up so that it comes to the midway of the arm. So this is the only possibility. Now there are two other muscles as well. You would come across coracobrachialis and brachialis. Both of them, the coracobrachialis of course is involved in shoulder flexion, but the brachialis is the one that is involved in um, elbow flexion. So you would think about the possibilities of these two ruptures, but these are not very common. The commonest muscle that would rupture in midst of exertion would be the biceps. So either you would see a bulge that is present in the upper part of the arm, which could be the tendon rupture of the long head, or else the bulge at the distal part of the arm, which could be the rupture of the insertion of the biceps. So as I said previously, the main action of the bicep would be flexion of the elbow joint and sometimes even a little bit of supination. But since most of the time, most of the common thinking pattern is that the biceps are more involved in flexion rather than in supination, because it's a very superficial muscle and it is a aesthetic muscle where most of the bodybuilders even like to show off with their flexion. So, but in the context of physiology, usually the flexion is carried out by a combo capability that comes with the flexion of both biceps and brachialis, not the biceps only. So, in circumstances when there is a bicep rupture, the brachialis would compensate. But in supination, the major activity is completely on the perspective of the flexion of the or flexion or the contraction of the biceps. Even though there is a separate muscle called supinator in the forearm muscle group, it does not have that much of a capacity for supination. The supination is more or less completely carried out by the bicep muscle. So in the context of a bicep rupture, more than that of the flexion would of course be weakened, but the brachialis would compensate. But when it comes to the supination is highly debilitated. So, as you all know, supination is actually the rotation of the forearm where the elbow joint and the proximal radioulnar joint both involved, and you see that the palm aspect of the hand faces to the front. So, in this movement is particularly carried out by the action of the bicep brachii. So, what would happen? What are the downsides or the disabilities that you encounter is that in such circumstances you will not be able to, for an example, would not be able to rotate a screwdriver, and sometimes will not be able to carry out rotation of the elbow, and these are the common disabilities that would be given by the patient when they present themselves. But of course, the flexion, they will say that there is a little bit of a weakness in flexion, but not very profound. And with this, usually what they come say, doctor, I can lift my arm, but I'm not able to twist things. Twist, cannot use a screwdriver. These are the complaints that they usually come up with. Right. The anterior compartment of the arm is composing of both the biceps brachialis as well as the coracobrachialis muscle. All these three muscles are provided by the musculocutaneous nerve. This musculocutaneous nerve is actually coming from the spinal cord, from the brachial plexus, but it has its origins from C5 and C6. Now, in another way, we can say that C5 and C6 will actually control the muscle contraction of all these three muscles. Now, as I said previously, the biceps and the brachialis is involved completely in flexion of the elbow joint, and the biceps play the major role in supination. So is it all right for me to say that C5 C6 actually controls the flexion of the elbow joint and the supination? Yes, it is. So if the C5 and the C6 integrity is there, the spinal sections are working, then the elbow flexion and the supination will be spared. So we'll go into this is how the next slide. This slide actually shows the course of the musculocutaneous nerve, and uh, this is a simple test that we can actually do in order to identify whether the C5 C6 action is there. You can tap onto the tendon of the biceps. With the bicep jerk, you can see that there is a little bit of flexion and also there is supination as well. You know that the C5 C6 is working. So we have come to the conclusion of our the clinical scenario that we have spoken, the clinical anatomy part. So if there's somebody who comes saying that there is a little abrupt sort of a bulge that has formed in the distal part of the arm with heavy lifting history, and also says that the flexion of the elbow is somewhat preserved, they can flex it, but the twisting movements are completely given out, then you have to think about the possibility of a bicep tendon rupture. Right, we'll meet with the next video.